Traction tables use external wrenches or internal motors and pneumatics to separate the split bench table design. They've been forced to use the term, well, decompression had to be redefined for FDA as unloading the spine, decompression as unloading the spine by positioning the distraction with positioning. They all have, basically, decompression tables have today the same definition, and they're classified as equipment traction power. Axial tables stretch axially, 3D tables, and an example of 3D tables, flexion distraction is a 3D table. Eccentrically, 3D active track. Linear table examples, Baxter, Spinal, one example of just a linear table. Here's a Triton table that was tried on the earlier patient that had been many years ago, no effect, but this will help patients with simple posterior disc herniations. I don't treat only simple posterior herniations. I treat people coming like this. And I'm not going to put them like this to stretch them. And that's what this is all concerned about. Flexion distraction, all familiar with what it does. Principal movement is flexion. It's classified as a traction table. And the load cells to measure pressure is an example of, as you've seen, made use of your practice. I never had much results with flexion distraction tables. For some reason, maybe it's the mechanics of the device that I developed or whatever, I get better results in this edition of my device. I think perhaps because I have a readout on the thing as a readout. I can have rate of force, Joe Divish 75 to 100 pounds, and I can change the parameters of force. Same movement, and different arrangement of cushions. So, for whatever reason, I've always injured patients on, for the most part, I have no effect with this. Various manufacturers call their type of traction decompression. Is there a difference between traction and decompression? They discuss it as, and they promote it as superior technology because of a non-linear pull. So when you graph time against pressure, instead of going up in a straight line, more time, straight proportional pressure, there's a little bit of a wave or bell curve. It supposedly reduces intrinsic muscle spasms in the sales literature, but there are no published studies indicating that's a fact, no controlled studies showing any proof to that whatsoever, large-scale studies that lowering the intradiscal pressure by reducing the compression, reducing the muscle spasm lowers intradiscal pressure. There's no relationship in the literature for that. Here's a table which we're all familiar with, the DRX. You can no longer use 86% results. I don't even go into my percentage of results with my outcomes and the outcomes of the doctors who use my table, because you know what it is? What is the success of chiropractic? Success of chiropractic is as good as you are. It's as good as your analysis, right? I mean, you have somebody down the street, and you may have corrected him. He's not a chiropractor. You may have come to your office and you fixed him because you're doing the correct maneuver or the right maneuver that the patient needs. You have a better experience in technique. You've taken more Parker seminars and you've learned more ways to treat. So this is unfair to say that any patient can be treated easily. And I've read many of it to get CE approval for selling the device in Europe that I designed. My technical advisor sent a 3-page document and said, this is not equivalent to decompression of the device. Then I sent a 50-page paper I worked on. So this is equivalent. And in covering all the research of all of these decompression manufacturers, all their research basically is flawed. Research that was done on here. Okay, or IDD therapy. Drugs administered 24 hours. Electrical stim was administered 24 hours. Ice and heat. And that's no way to run a clinical controlled study and introduce all those other things. Baxter manufacturers says basically 2 things. A guy writing for Baxter, Talalo, writes that he can't find any available data that conventional tractions tables reduce intradiscal pressure, and that many back steep patients who receive back steep therapy and have chronic back pain have failed numerous modalities, including traction. So their success to get positive results means that it's not conventional traction. Well, the FDA didn't like that very much. And he basically said that the claim of uniqueness must be stopped because they have not proved that their traction is any different than any other traction pole in terms of results. Here's a back steep table. To me, this is not chiropractic. There's no movement, there's no specificity, there's no range of motion, there's no proprioceptive stimulation, it's stretching. And that may open the disc worse in a prone position. This patient may have relief in extension, and they're now facing down. They should be face up. The Washington State Department of Labor and Industries concluded that the published literature in their industry reports did two technical assessments on the effectiveness of traction on using intervertebral decompression. Both reports demonstrated that the literature has not shown that such devices are more effective than any other type of device we use. Also, the classic study of the Ramus and Martin study, where they stretched on the back steep and they pulled, they found a precipitous drop in pressure. And that's supposedly unique to the back steep. Napkinson, the father of all those pictures that we see, where we see sitting is this much pounds, nanometers of pressure on the spine, and standing is less, and laying down is less, and sitting is 240 millimeters of mercury on the spine. Napkinson says that study was flawed. No temperature when they inserted the catheters into the patient's disc to measure the intradiscal pressure. That they didn't calibrate the negative readings, and it wasn't a close distance to measure the pressure. Do I believe that necessarily? I really don't. I really believe that all decompression tables, all traction tables, lower intradiscal pressure equally. But here's the kicker. In all of my research, and the more I work with ExtendTrack, the more I believe that ExtendTrack works and flexion distraction works on the principles, and even linear tables may work on the principles of chiropractic, reducing subluxation and mechanical failure. There is no correlation between improvement of symptoms and lowering of intradiscal pressure. It's a phenomenon that occurs when you stretch. In fact, Gay, of the Department of Physical Medicine of Mayo Clinic, states that all distraction markedly reduces intradiscal pressure. He did a study with flexion on flexion distraction, measured it, lowered the pressure. He replicated the Ramus and Martin study with linear pressure, reduced pressure. And he said that the effective distraction appears to predictably reduce nucleus pulposus pressure. Now, theoretically, we can scroll down to another study that was done, discovering that the work of Alf Napkinson, where we want to know at 25 years old, we lose the vascular supply of the disc. At 25 years old, how do you get fluid? How do you dehydrate the disc? How can it be communication? Everything's cut off, there's no circulation. So he found ampulla, little canals from the disc to the end plates of the vertebrae where fluid could diffuse. So he injected aniline blue dye into the body of the vertebrae, applied traction to segments, and lo and behold, to his amazement, dye came into the disc. So that gave birth to the whole concept that decompression rehydrates, brings electrolytes into the area, and as a possible mechanism for the benefits of decompression. Always say possibility when you're dealing with patients, so it's a possibility. So all reduce pressure. That means that Baxter reduces pressure, the work of Gudavalli and Cox. In their study, he looked at Gudavalli and Cox. He couldn't get flexion distraction to go into the negative range, as Gudavalli and Cox did on the Cox flexion traction table. But that's because his amount of distractive length was measured after 1 or 2 minutes. Coccygeal volume measured the precipitous drop in intradiscal pressure within the first half a minute. But it's neither here nor there. That's a phenomenon like smoking. You have vapor come out. There's no correlation between drop in intradiscal pressure and any correspondence to clinical results. I think, as Gay thinks in his paper, Stress and Low Blood Discs During Distraction in 2007, as he states, he believes a lot of the relief on these devices is not from the drop in intradiscal pressure, it's from the mechanical changes that take place. The arrangement of ligaments, the elongation of ligaments, the mechanical effects is more than intradiscal pressure. So when we study the effectiveness of traction in general, and we're trying to get reimbursement from insurance companies, here's a study by Clark. 2,177 patients, 10,000, 16 received traction. Their outcome: continuous, intermittent, motorized traction against placebo, sham, and other treatment. Not effective. Traction is probably not effective. They're not saying it's definitely not effective, but the evidence is not overwhelming that it's effective. So perhaps that's why these traction devices that are sold and marketed, linear devices, are basically not doing what they should be doing. And if you get results on the device that you use, you're always going to have patients who'll be able to pay for the device. And you'll have new patients. If this many patient population of all these traction devices on randomized control does not work, there's something wrong. And I think it has to do with linear versus three-dimensional. That's my opinion. Lack of movement when you're doing the manipulation, traction manipulation. So let's go on to the next slide. What does the research show on this, on intermittent mechanical traction? What is the big Schlemiel? This is the Schlemiel study on a linear, high-end decompression table called intervertebral differential dynamic therapy. This is used to be called axial decompression, or whatever. It's now this is manufactured by intervertebral differential dynamics. They added it to a standard guided activity program. It took 60 patients, divided in half, 30 patients sham with a guarded activity program, and 30 patients with the active spina. They used 4.5 kilograms, 10 pounds for the sham group. They followed protocols of manufacture, 50% of the body weight gradually achieved, plus 10 pounds. Okay? The added axial intermittent mechanical traction to a standard graded activity program has been shown not to be effective. So you have the VAS scale as a standard of measurement of symptomatic improvement. Backstage, 61 in patients to 32. When you add just the sham alone, just slightly less. So according to them, there's no difference in intermittent mechanical traction. It's a failure. Here's an updated Cochrane database review on the outcomes of 32 randomized controlled trials that selected 2,762 participants, measuring chronic pain, subacute pain, and physical therapy plus traction. Results? These findings indicate that traction, either alone or in combination with other treatments, has little or no impact on pain intensity. That's the VAS scale, functional status, disability index, global improvement, and return to work among people with low back pain. So I think there's problems with both the administration, the analysis of how you put a patient on these devices, and the positions they're in, and the static nature of it. We're not meant to treat patients in a cast. Right? I mean, imagine adjusting a patient like this. Don't move. Let me adjust you. I think it's not us. Right? Here's the extent track device, hand feeding device, and we describe the protocols as 4 basic protocols. There's so many different things that one can do with a device that has all these functions. So particularly, we have a big presence in Moscow and St. Petersburg, Russia, to the athletes and the athletic hospitals. How do you, through translation, describe all the many, many positions a patient can go in and what circumstances? So we basically designed 4 protocols, protocol 1 through protocol 4. And you notice that there's different positions. Prone. Half of my patients get well in the prone position, just the way it is. And if I don't get them well in the prone position, they may get well in the vertical position. Flexibility of treatment. If you're doing, and if you're sticking to one position and you're not getting results, move to the next position. Because for all your analysis, you may be wrong. And my patients tell me that, doc, I'm not feeling well with this. I have a patient with stenosis, and it dictates commonly you put an inflection because it opens up the canal. And we'll see why. I'm going to show you the radiology of why it opens the canal. And I'm mediocre. She says, when you first treated me, you put me on my back in extension, protocol 4. Supine patient, horizontal. You know what? Big improvement. So you have to it's an art, just like how you give an adjustment, right? You can't always give the same adjustment the same way, right? Get the same results. What did Einstein say? Definition of insanity is. We all know what that is, right? How many knows what that is? Okay, I don't have to say it, do I? I'm not going to say it. Doing the same thing over and over again and expecting the same results, different results. So there are many positions that you can place a patient in, and you can do many of these things on any device that you have, right? Lateral flexion is very important. I find lateral flexion key. I find vertical positioning key. 50% of my patients, particularly older patients, I never put horizontal. There's no reason to challenge their chest, respiratory problems, or this gets them well, I stick with it, particularly in the prone position. Dynamite, plus the manual therapy you do with it, manual manipulation you do. Excellent. What position do you put a patient in? We listen to the body's innate intelligence. We all know what innate intelligence is. That's the foundation of our careers. And we listen to it, and we look at the patient, and we observe. I had a physical therapist who came in to observe me about a year ago on a patient with severe leg pain. And I immediately put the patient in protocol 1 flexion without moving the leg piece right or left. And she said, wait a minute, didn't you notice the patient? The patient has an antalgia, an involuntary muscle spasm. I said, you know what, you're right. She's a shift, we call it a shift. Rather than just doing this, we move the patient leg piece towards the pain relieving position that we tested in provocative range of motion testing, which we do with each patient. So we customize the approach to each and every patient. That's what we should be doing. Customizing treatment care plans and categorize. We have to categorize the lesion. And I made it easy for myself. There are only 3 categories. Medial disc, lateral disc, central disc. It doesn't have to be herniation, derangement, dehydration, loss of elasticity, subluxation, but it's how you test the patient that determines what position the 4 protocols you're going to put the patient in together with the visual pain scale. So here we have provocative range of motion. To actually test the patient, can I have a volunteer to show up on YouTube? You weren't exactly a volunteer, I pointed to you, right?
Yeah.
We'll give a shake. Very good. So each and every patient comes in. He's not obvious. He's very, very straight. No obvious changes, but he has leg pain, where he has intermittent neurogenic claudication, right? So he's pain down his leg, can't walk, probable diagnosis of stenosis. Commonly, I would put him in flexion, open up the canal, which he's lost on disc space. His lateral recesses are closing. flexion, as the literature dictates. So our testing always flexion. That would be pain. It's pain down the right leg. Thank you very much. I really enjoyed having any questions.